Hi, welcome back. Congratulations, you made it through the 3 webinars on the collaborative care model. You get an awesome prize. I don't know what it is, but I'm sure it's something fantastic. Now we're in our 4th webinar, I think, 4th webinar. And let's recap just briefly who I am and what we've been talking about. My name is Eric Vanderlip. I'm a physician, psychiatrist, family physician in our departments of psychiatry, medical informatics, and family medicine at the University of Oklahoma School of Community Medicine. And I live and breathe these models of, integrated care, which is where we started this whole webinar thing. So integrated care is blending behavioral health and primary care services. There's a two-way street between primary care services to behavioral health settings and behavioral health services to primary care settings. It's a continuum between less integrated models and more integrated models. The more integrated models are things known as collaborative care. And collaborative care is built off of something called the chronic care model. And we like that because in many ways that's what our population is shifting towards. And the first webinar of collaborative care was all about chronic conditions and non-communicable illness, and that's where we're trying to reform our healthcare services to be less like just goalies and more like an entire team to take care of people and score instead of being scored upon. Then the next one was about the evolution of the collaborative care model out of chronic care models. And then thirdly, we talked about adapting the collaborative care model into community-based settings. This webinar is about data, registries, measurement-based care, and population-based care, and how you take those measurements and that registry and work it in, and how that looks and what it looks like. So we're going to be talking about all those things, in addition to the essential elements of measurement-based care, which is one of the components of the collaborative care model. I don't have any disclosures. Oh yeah, remember this thing? Lame-o, right? It's so 1990s. But yeah, we got to go over it again. It's so important. Remember, we get these prepared, proactive practice teams and informed, activated patients that have productive interactions and lead to improved outcomes. That's what we're looking for in the healthcare system now. I feel like a broken record when talking about the chronic care model, but it's because we're talking about managing chronic conditions and a population health focus. That's absolutely essential in modern healthcare, and it's absolutely essential in the world of behavioral health. Today, we're talking about 2 aspects now of this chronic care model in this collaborative care program. We're talking about clinical decision supports and information systems and how we design our services. This is a screenshot of that. These are the 4 essential elements of the collaborative care model. We'll talk about team-based care a little bit later, and we're not going to really talk about evidence-based care because we kind of assume you know how to treat things in an evidence-based way. What gets measured and what gets paid attention to. So as part of these collaborative care models, these registries and what we put in these registries is very important. The measurement-based care focus and the outcomes of these models are an essential aspect to helping us move forward in healthcare. And they're very powerful tools. We have to be very careful about what we include in these tools, because if we put the wrong things in there and we can't change them, or they can't be measured as frequently as we need them to be, then they're not going to change, and we're going to be very frustrated. So, I want to go through briefly 6 major components of effective measurement-based care outcomes. So they are number 1, that measurement alone is not enough. If you're going to be measuring something, it has to be reincorporated into the clinical context. We'll be talking about that for the latter few minutes of this webinar. Patient-reported outcomes, I hate to say it, are generally better than clinician-reported outcomes. So the more that somebody is rating themselves on how they're doing, the more accurate it probably is. If we're doing it, a general principle is that we're subject to bias and we could be biased, and its beauty is in the eye of the beholder and outcomes are in the eye of the beholder, and that's the patients, not us. That's a basic principle of this. Measures must be collected frequently to accurately assess the most recent clinical state. If you've got a measure that can only be collected once every 5 years, then that's not going to be very helpful for you. If it's once every 6 months, still not very helpful. Maybe once every 3 months, we're getting there. Ideally, once every couple of weeks, if the condition is changing with that rapidity. you need it to be matched closely, or measures have to be tightly correlated to the illness state, and they're typically diagnosis specific. Diagnosis specific because that allows us to put an evidence-based treatment algorithm for that diagnosis or that condition on top of that measure, and that helps us get it better. Instruments that we use to measure these things must be reliable and sensitive to change over time, and they have to be relatively simple to implement and low cost. If we violate any of these things, it makes it less likely that our measurement-based outcome will be effective. So let's talk about this. So measurement alone is not enough. Outcomes must be incorporated into the clinical encounter. There are things like bad rulers and good rulers that we can use. Bad rulers, if you Google it, are Stalin and Hitler and stuff. Good rulers are things that allow us to take that measure and we could put it into a clinical context. If some of you have heard of PCORI, which is the Patient-Centered Outcomes Research Institute, as part of the Affordable Care Act and the Center for Medicare and Medicaid, patient-centered outcomes and research into patient-centered outcomes is a huge new force of attention and funding at the level of the federal government. We've got to have better patient-centered outcomes if we're going to move our healthcare system forward. And that's because patient-centered outcomes and patient-reported outcomes are generally better than clinician-reported outcomes, especially if it's not something we can measure through a blood test or a neutral measurement that's agnostic to who's reporting it. Measures have to be collected frequently to accurately assess the disease state. Like I was saying earlier just a second ago, if it takes us 6 months to assess something and we can't do it rapidly enough and somebody's state is actually changing, even if it's a reliable measure, but we can't track that because we can't collect it frequently enough, then we're going to be frustrated because we're going to be thinking, well, he's actually better, but the number still says he's worse, and so we're distracted. When we're trying to use that registry, we're distracted, and we have to refocus our efforts. If it's something that's real time, that we know is an accurate representation of how they actually are based on the last time we changed our treatment for them, then that's something I like. Measures must be tightly correlated to the illness state and are usually diagnosis specific. If diabetes is getting worse, I want my measure to get worse. If depression is getting worse, I want that measure to get worse. If their housing status is getting worse, I want that measure to get worse. It's got to be tightly correlated to the illness state. And here I use illness state pretty loosely. It could be anything, their wellness state. But then if it's wellness, I've got to know what's impeding their wellness, and I've got to know how to treat that. So we've got to think about that. That's why having disease-specific ones are a little bit better because I know how to treat those things. Instruments must be reliable and sensitive to change. If things are actually changing and our team is actually doing a good job of changing them, I want that instrument to reflect it. If it's not, and it's not consistent over time, that's pretty frustrating to me and would be frustrating to you too. And finally, if it's something that's very expensive to obtain, if it's skin samples and punch biopsies or biopsies in general, that's not very pleasant and that's pretty expensive and rather dangerous. So we're not going to be able to do that very often. So that's a less seductive measure as compared to something that's something easy, like maybe a blood test or maybe a blood pressure. I like blood pressure because it's easy to take. It doesn't take a lot of time or effort to obtain one. So when we think then again about this model and putting these measures into our matrix, our registry, we've got to be very careful, but we could approach it from this biopsychosocial approach. I've talked about all these slides in our last webinar, and I'm not going to go through them in detail, but I'll throw them back up because we've got to think critically about, from the biopsychosocial angle, what are our measurement-based outcomes in these other things, and the social determinants of disease, et cetera. And keeping that registry as simple as possible will help our teams not get overloaded when we have to look at these numbers frequently, once a week, once every 2 weeks, to reassess where our team is and how we're doing across our population. This was just published in a major psychiatric journal a couple of, even last week, I think, in August of 2016. a tipping point for measurement-based care. This is a meta-analysis looking at a number of trials that used measurement-based care in the behavioral health world. And we, as behavioral health clinicians writ large, have yet to really grow accustomed to measurement-based care because we don't trust them. We don't like things like PHQ-9s because they're subjective. But we've got to get something. We've got to get some kind of rating scale or something. And we know now definitively through lots of large-scale efforts that when we employ these measures, these scales that have been validated over and over again consistently, we have high yields in our populations. The question is, and this is their conclusion, in addition to the primary gains of measurement-based care for individual patients, there are also potential secondary and tertiary gains to be made when individual patient data are aggregated. When we do good measurement-based care, we can be held accountable for the care we provide. We can actually demonstrate from the behavioral health world just how well we're doing and how much work we're doing and the outcomes we're achieving in the services that we provide in our recovery-based services and our substance abuse services. All the good work that you're doing out there, when we employ these scales and these outcomes consistently, we could demonstrate and show how well our populations are doing when they're able to see us and work with us. So when you have a registry and you're sitting there and you could see all the patients in it, what do you do with that? How do you form a team and how does your team work around that? That's what I've got to talk about for the next few slides. How do we make that alive, a living, breathing document that we use day to day or week to week? That process, what do you do with these measurements, is called team caseload consultation. Looking at your caseload of patients across this registry and focusing on those measurement-based outcomes is a process. And I want to take you through what we learned at the University of Washington as basic elements of this caseload consultation. These slides are provided in part as part of our training for team care, which, as you remember, is multi-condition collaborative care. And when we sit down as a team, that behavioral health specialist, a psychiatrist, and a primary care physician consultant, and that care manager, basic principles that we found to be useful in these team-based caseload consultations. There is a nice link through some of these slides to an intervention guide that you can download for free based off of a multi-condition collaborative care program that has many of these resources embedded in it if you'd like to think about using some of these templates and team-based documentation forms to help your team make best use of these registries. It's important to remember that as a team, you're a team working together. And having mutual respect is super important. Collaborating and learning and synthesizing everybody's skill sets and perspectives and respecting everybody's skill sets and perspectives is vitally important to that team functioning well. Giving everybody a chance to have input around the table is supremely important in your team-based consultations. So, there's a hierarchy that you can use in this consultation. When you have this registry, you can sort by the certain measurement-based outcomes that you're focusing on in that caseload review process. And you can go by new patients recently enrolled in the program, number one. Number two, ongoing patients that haven't reached their targets for those 4 disorders in team care. It was diabetes, cholesterol, hypertension, and depression. And then those who are presenting challenging patient care management relationships, the squeaky wheels. Notice how they're third, not second or first, third. And then patients who we've lost engagement with that we haven't gotten off the caseload yet. And then finally, maintenance patients, people who are doing well. Sometimes you may not even get to them, but you know that they're doing well because you can see it on your dashboard, on your registry. Setting it up this way is absolutely essential so that you can focus your efforts during that consultation process on not just the squeaky wheels. There's some squeaky wheels who aren't getting better yet, but sometimes if you miss the low-hanging fruit of those who just haven't met their targets, you can think more critically, and you've got to bake that into your policy and your procedures for how you do this caseload consultation. So sort by PHQ-9 scores, sort by blood pressure scores, sort by diabetes, hemoglobin A1C scores, and that will allow your teams to focus on those who haven't gotten better yet, and then talk about the squeaky wheels. The squeaky wheels will always get talked about. It's nice to have maybe 5 minutes to 10 minutes to talk about new patients as a team. and then spend relatively less time talking about the people who aren't doing as well, and then even less time talking about maintenance patients. So 5 to 10 minutes for new patients, 2 to 5 minutes for ongoing patients. This is what they did in team care, where people had uncontrolled diabetes and depression. That's how they got into the program. And then they met as a team and had to manage 60 to 80 of those clients in a primary care setting. In community behavioral health, it may be a little bit different, and there might be a little more time that needs to be allocated to ongoing patients, for instance. But you want to be cognizant of the time to make sure that the team makes it through all of the caseload and talks about everybody that needs to be talked about. That's why you have a registry. Here's some screenshots of the registries that these systems have used. When you're doing the basic outcomes, the person presenting on the new patient can follow some basic guidelines. It's important to talk about who is this person, what their medical problems are, their current and past treatment experiences, and their goals and care, especially when introducing them to the rest of the team. And for ongoing patients, there's some basic things that are nice to touch on. What was their action plan from the last case review if they haven't met their clinical targets yet? What is their progress or barriers on that action plan? Update it, and then have the care manager work with the patient and the PCP on new suggestions and new tasks that team kind of assigns. There are certain good questions that you can ask during this case review process. What are their current outcomes versus their targets? Where have they come from? Where are they going? So is their hemoglobin A1C still super high, and where were they to begin with? What are they doing to engage in their own self-care? And you could be critical about this, and it's important to be critical. Have we really done a good job about educating them on how to care for their diabetes or how to care for their X, Y, and Z that we're monitoring? And where are we with regards to treat to target, and what's our next concrete time that we're going to follow up with them? These are all good questions to think about through this caseload review process for each individual ongoing patient. Somebody can take notes during this process, but it generally shouldn't be the person kind of in charge of running this caseload review process. It can be somebody else. And it's nice sometimes to rotate that scribe around. Here's an example of a note sheet that your team could use. So you have a patient ID, the next contact, and the action plans or the tasks for each of those people. And over at the right, in this example, they've even included some of the suggested actions to prompt the team. So there's things like motivational interviewing. Have we really done that? Do we need to go back to the basics of that? Disease self-management. Have we educated them again and made sure they really know everything about diabetes or hypertension or hepatitis C or depression or whatever it is that we're focusing on that our measurement-based outcome is trying to achieve? And sometimes it's nice because sometimes you can really feel stuck. Here's an actual screenshot on your slide deck to show you what these notes look like. Here's a note: increase citalopram to 40 milligrams, ask Dr. K about 30 milligrams for a month, then increase to 40 milligrams. That's a definable task that is like a little quanta of an evidence-based recommendation that we've got to follow up on as a team. We can assign those tasks to different team members, and then when we follow up again, whether or not they've been accomplished or not matters less as compared to if that person is getting better. If they're not getting better, then we've got to troubleshoot why they're not getting better. Oh, well, we forgot to talk to Dr. K about that citalopram. We got to do a better job about communicating with them and seeing that those prescriptions are actually sent off. Or do a better job about actually doing behavioral activation with the patients and getting them motivated and doing things if depression is our focus. Making this caseload consultation process part of the routine and the expectation is vital. Getting this routine down takes some time and practice. It's not simple. And at the beginning, it takes a long time for everybody to get used to who they are. But in your team is where you integrate your care. And in your team and on your registry is where you integrate your measurement-based outcomes. It's not about integrated care. It's about setting up the right system to allow your teams to integrate care and thrive. So we can design this. It's not about integrating care. It's about a chronic care management system. And picking and choosing the right measurement-based outcomes is vital to that. In the Department of Mental Health, there's a lot of different places you can be getting your outcomes and your data. Part of it can be from Care Management Technologies and their Health Home Registry. Part of it could be from a health information exchange, My Health Access Network, which could be delivering you some basic clinical variables, the most recent blood pressure for somebody, or maybe their lab results. And another part could be your own electronic medical record, where you're drilling down into individual patient charts, and that's generally where you can abstract the data to assimilate your registry that you'd like to put together. Some of these products hopefully will be able to deliver this registry to you automatically, but that capacity isn't necessarily baked into our systems yet. If you can operationalize this model of care, I think it better approximates what the needs are for our healthcare system, what the needs are for our patients out there, and I think you'll have less burnout. It also optimizes the ability of the team and so that they can work at their highest level and gives them the capacity to witness change. Two essential elements to engaging your team and preventing burnout and turnover. And that's what we're going to talk about in the next webinar. That's all I have to say for this one. Thank you.